Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Halley, hospice social worker. Today, it's just Penny and I. It should be your favorite episode. We're going to do long-form education today about disease progression. And specifically, we're going to focus on diseases that may appear to be self-inflicted at times, but we're going to treat them the same regardless.
Correct. I think we should say long-form information or storytelling, because I think if people hear education, they're going to be like, tune out.
Very good.
And we know it's way more exciting than just boring textbook stuff, right?
Of course. But, we have a little bit more time to flesh out our ideas when you're now on TikTok and you're doing your education pieces or long form storytelling. It's still only a few minutes.
Yes, this is true. So we do have some more time to take a deep dive.
Yes. So let's just jump right in and let's start with heart disease. So just as a foundational approach to these, as people are listening, we're going to talk about what the disease is, what you can expect from that particular disease, what kind of symptom management that we're going to use to treat that, and what kind of death might you expect. Because really, that's the important part we want you to understand is there are some deaths and some diseases that are definitely scarier and or may take more symptom management to not be scary. So we don't want you to be afraid. We want you to have information and be prepared.
Right, but we may as well skip ahead and talk about the fact that most of these diseases, if not all, will result in the same type of death at the end. Like we're going to see the same dying symptoms when somebody is actively dying. They're having a natural death, meaning there's no medical intervention that's keeping them alive or prolonging their life, and they're dying from natural causes most of the time. I've had some patients on hospice that didn't die of natural causes, but it's going to be a similar approach to the end of life. People look the same at the very end, when you say, Halley.
Yeah, I totally agree with you. I think what I'm thinking of, and specifically we're going to get into this, I think, with the heart disease, is there can be more symptom management before we get to that active dying stage. And that's what people worry about when I've had people come on earlier and they've had time to ask questions about that. The things they're worried about, especially breathing. We're going to talk about COPD today. So there's going to be some symptom management things that I want to make sure we're reassuring folks, especially you, Penny, on the nursing side, can give people an idea of what kind of symptom management we can use.
Right. Yeah. So in shortness of breath, so let's go ahead with end-stage cardiac disease. People who come on hospice have end-stage cardiac disease. So we are looking at shortness of breath with that disease. We are looking at fatigue. I like the term chair-to-bed existence. People can't really get around anymore. They're exhausted. They're very fatigued. We can see chest pain sometimes with end-stage cardiac, but it's really weakness, fatigue, shortness of breath. And some might think that fatigue isn't that bad of a symptom, right? So you're just tired, whatever. But, I've known patients who have fatigue who, it's exhausting. It's exhausting to be fatigued, to not have the energy to do what you want to do, especially when you're looking at the last part of your life and you do want to try to check off your bucket list, but you don't have the energy to do that anymore. So we treat cardiac disease symptoms with oxygen. That's something that we use very often successfully with people to kind of give them a little more energy. We can give steroids, but we typically don't use a lot of steroids for end-stage cardiac. But if somebody's very fatigued, we can. That'll give them a little perk up. And then, of course, morphine, is our gold standard for shortness of breath. So we can treat cardiac disease with that. We may also see with cardiac disease a lot of edema, especially in the lower extremities. So we can see swelling in the legs, weeping edema. We sometimes see where the legs are so swollen that they're literally like weeping. There's fluids coming out of the legs. And unfortunately, there's not a whole lot we can do for that. We can give diuretics to people, and that's the water pill that, makes people pee more. But when we see it at such an advanced stage, that doesn't usually help very much. And so it's more just kind of managing that with, wrapping them, keeping them elevated, putting chucks under them.
Well, and as you're speaking of things, Penny, I'm going to jump in like I'm the listener and ask questions that I have been asked by patients that so they can understand that. So I want to go back to shortness of breath.
Okay.
So what causes shortness of breath when you're talking about a cardiac type of terminal illness?
A couple things can cause it. If they have congestive heart failure, fluid around the heart can cause the shortness of breath. Or also because the heart's not pumping oxygenated blood, that can cause shortness of breath.
Hmm. And then with the fluid, I know I've certainly had folks that had little tree trunk legs and it was really hard for them to walk.
Yeah.
And of course, oftentimes those folks also don't feel like they can breathe very well when they do put their legs up. So they're in this kind of forward leaning tripod stance to relieve their breathing. They often will have their legs down, which of course then the edema does not get better. So I know we at our place have used massage, very gently and very specific type of massage
Yeah.
to alleviate
Lymphatic
some of that.
drainage.
Mm-hmm.
Lymphatic drainage. Yeah. And when we're talking about somebody whose legs are just so profoundly edematous, you're going to you're always going to look towards whatever is going to make them feel more comfortable.
Mm-hmm.
And the breathing is a biggie, right? People don't
Yeah.
like to not be able to breathe. That's real true suffering when somebody can't breathe. And so if they have to have their legs down, to be honest, I mean, I've had patients who kept their legs up all day long and it didn't matter. Like the
Mm-hmm.
edema is so massive that it doesn't even help to keep the legs elevated. We
Mm-hmm.
would I mean, and whenever I talk about stuff like this, somebody will pop into my brain, right? Somebody will pop into my mind. I'm like, oh
Yeah.
yes, I remember this one patient.
Mm-hmm.
Her legs were just giant and we wrapped them tight, tried to wrap them tight with bandages, kept them elevated, and it didn't work. Nothing worked. They were just so huge and just leaking, constantly leaking, changing the chucks pads out from under her legs, you know,
Mm-hmm.
every half an hour, every hour, because they were saturated with
Yeah.
body
Yeah.
fluid.
I do the same. I have people pop into my mind as we're talking, and I can think of one particular patient that they actually their end was sitting up in bed with their legs down on the ground, and that's how they died because it was the
Yeah.
most comfortable position. I've had a lot of folks kind of living back and forth in that chair to bed existence, but oftentimes mostly in a recliner because
Hmm.
that's what was
Hmm.
most comfortable.
I know. I
And
joke that hospice nurses have to be able to put a Foley catheter in a patient who's in a recliner because
yes.
so often that's where they live. They live in
Mm-hmm.
that recliner.
Yeah. And sometimes wrapping it is more uncomfortable than the
Mhm.
actual weeping edema. I mean,
If it's weeping, at least you're getting some of that fluid out of there,
mm-hmm.
and the wrapping doesn't really help. So
Yeah.
yeah,
That's a tough one because there's just some things we're not going to be able to prevent, but certainly we can help people with different forms and things and ideas to try to make them a little more comfortable.
right, right. And also speaking about the medications that we use to manage, people often think that we immediately stop all medications for our patients when they come onto hospice, and we
Mm.
don't do that. We do a thorough medication review, and the doctor will determine what is really going to still benefit the person. So we aren't necessarily going to stop medications that could benefit the person. We might still give nitro tabs if needed for somebody that is having angina,
Mm-hmm.
heart,
Chest pain.
chest pain. Yeah. Or diuretics, like I said, that we still are going to I knew I was going to say, a million times. And here I am doing it.
Only because you're in your head about it.
And you don't know. I say, you know, but you don't know. I'm actually telling you.
Yeah.
Okay.
Yeah, that's a great point about the med review, because we do have people that come on and they're afraid that they're going to have their medications taken away. I know a lot of
Right.
times that has to do with other side effects too. Not just, is this the most effective at this stage of life, which I've heard our doctors say a lot, but it makes me think of drugs like warfarin, for example, that may make you
Mm-hmm.
a more of a bleeding risk or a fall risk. And so it's important
Mm-hmm.
that we have the conversation of not just, hey, we're recommending that we take this medication off your list, but here's why.
So as a case manager, I was the queen of getting people to stop taking their warfarin, which is also known as Coumadin. It is a blood thinner, and it requires blood tests to make sure that your dose that you have is effective and not too much. And so we would do, it's called a PT-INR, and we can do that test in the home with a little handheld device, and we have to poke people's fingers to do that.
Mm-hmm.
So immediately I would always talk to the patient about, do you want to keep getting your finger poked? Or
Yeah.
would you like me to talk to your doctor and see if we can switch you to something else? And we would typically switch them to an aspirin and take them
Mm-hmm.
off that. So that is something that I always like to do. But I found, people don't want to get rid of their medications, but I've also found that some people are really happy when they get to,
Yes.
because a lot of times when they come to hospice, they are taking a handful of pills. And
Mm-hmm.
so, and they're choking them down. They're hard to swallow. You've got this whole cup full of pills. And so I found that patients are usually pretty happy to get rid of them. But there are those who don't want to get rid of anything, including their vitamins and minerals and their
Oh, yeah.
cholesterol lowering medication.
I was just going to say statins
Yeah,
because
statins, yes, which have terrible side effects too, by the way. Statins are not necessarily the best drug to take if you're dying, especially. But taking these medications away sometimes makes people feel better in the
yeah.
end. And I can't blame them for wanting to keep taking these things, because what are they told?
Mm-hmm.
You need to take this.
Or you will die.
They're told by their doctor, you need to take this. You have high
Yeah.
cholesterol, you need to take this. You need to take this vitamin. You're low in vitamin D, you need to take this. You're low in calcium, you need to take this. So then we're telling them, no, you don't need to take it anymore.
Mm-hmm.
What do you mean? I've been taking these for years. My doctor said I need to take these for years. I've been taking these. So
Well, I
it
think
is,
that's where that education piece comes in. That's why you
yeah,
have a holistic team, and that the patient is a part of the plan of care. You're not just having that paternalistic relationship where you're saying, I know what's best for you. We're
right.
coming in and saying, here are some possible improvements in quality of life, improvements specifically related to your medications. And here's why we're making these suggestions. Now, there are going to be times when you're on a medication that is really expensive. And
Yeah,
we've talked about this before. We only get so much per day per Medicare patient,
yeah,
and we just can't afford it.
yeah,
And there's going to be an evaluation of whether or not that medication is still effective, whether there's a different medication that might work better and it's
right.
less expensive. And so we're going to have those conversations.
Right, right. Is it effective? Is it going to benefit you? Does the
Mm-hmm.
benefit outweigh the risk or the cost, which we do unfortunately have to think about?
Mm-hmm.
Yeah. So now we've gone down a different
As
different
all of our
pathway.
conversations.
I know. I know. We
Nothing is
don't
an
need to.
easy conversation when it comes to
No, there's
hospice
so
and end of
many.
life.
And so stay want to stay with the medication thing again. So that I think sometimes when we're talking about these conversations that we have with people, probably the best approach is to ask them, what do you think about taking all these medications? What would you
Mm-hmm.
think about maybe streamlining your medications? Open-ended questions about how they
Yeah.
feel about taking these medications,
Mm-hmm.
and what are your concerns about stopping these medications?
Yeah.
You
How would
know,
you feel
keep,
about
keep
having
those.
a reduced pill burden? Talking
Yes,
about taking
reduce pill
handfuls of meds.
burden.
Yeah.
Yes, yeah. My dad had pill burden before his death, but he was the kind of patient who wanted to take those pills.
Yeah.
He was all about it. He had his little pill case, and he took everything he was ever told to take. It's interesting that he did that. He wouldn't do anything else that the doctors advise, like quit smoking. But take the pills, take all the pills. Yeah, I'll take all the pills, no
Oh,
problem.
taking something is very different than quitting something.
That is true. That is true. Good point.
And
Good
and
point.
that's a great
Plus, he felt like,
segue.
yes, okay, yes, let's do a segue here. Back to our topic. We're going to segue back to what we were supposed to be talking about in the first
I
place.
know. It's a great segue into COPD. So Penny, tell us what COPD is
COPD,
and what that looks like for folks.
chronic obstructive pulmonary disorder, which is kind of an overarching term for lots of different respiratory diseases. So, like if you have bronchitis more than I forget how many years in a row, then that's considered COPD.
Mm.
Emphysema is COPD. So anything that is caused by your lung failure basically is under the umbrella of COPD. Although we typically refer to things like cystic fibrosis as cystic fibrosis. That's its own disease, but it has the same type of, well, not necessarily the same type of symptoms. But COPD causes people to have a reverse in their respiratory drive.
Mm.
And I should have studied up before this so I could remember exactly how to say this. But so we are not driven to breathe by a lack of oxygen. We are driven to breathe by a presence of carbon dioxide. And when a person has COPD, their switch gets flipped. And so then if you give them too much oxygen, it can actually cause them to suffer shortness of breath or to have respiratory failure, because now the body is responding to too much oxygen in the system instead of too much carbon dioxide, if that makes
Mm.
sense.
Mm-hmm.
And hopefully nobody's going to be like coming back at me like, you said that all wrong. But that's kind of the whole idea, right? Basically, COPD means a person is very, very short of breath. They have air hunger where they can't breathe very well. Again, fatigue.
Mm-hmm.
Again, chair to bed existence.
Mm-hmm.
Tripoding so they can get their breath, sitting like a triangle, tripoding to catch their breath. Very uncomfortable. I would say out of the patients that I've cared for, pain is bad, but air hunger is worse.
Yeah.
People who can't breathe really, really suffer. They
Mm-hmm.
panic, they have high anxiety.
And that's
It's,
such a vicious circle, that anxiety, because of course, physically, you are struggling to breathe. So
yes,
it is not in your head that you can't breathe. You can't breathe. Then you become anxious. Once you're anxious, it's harder to breathe, and round we go.
exactly, exactly. And so the response is people want to turn the oxygen up, and then
Mm.
that doesn't help. That does not help.
Right.
We use lower flow oxygen for COPD patients. They can also have the same types of swelling in their legs and their hands, same type of thing. Circulation is poorer. They can still have those types of symptoms as well. But again, morphine, gold standard. That's what we use to treat COPD. Steroids really help. In fact, I remember before I was a hospice nurse, I worked in a clinic and I would have COPD patients who would come in and they want more steroids, because steroids can make them feel so good. They can breathe so much easier when they have steroids. But the side effects of steroids definitely, prohibit long-term use. We cannot use steroids ongoing for long-term. Usually what we'll do is we'll give steroids in a big dose, like a big blast, and then we taper them down off of them.
Mm-hmm.
But they can make brittle bones. So if people have long-term steroid use because of COPD, oftentimes they'll start having pathological fractures from that. I've had patients who had pathological fractures because they have brittle bones from steroid use.
And not even counting how irritable you can get with your caregivers on high doses of steroids.
Irritable, insomnia, yeah, agitation, giving steroids, you got to give earlier in the day. It, again, though, steroids are one of these drugs that are really fantastic sometimes for
Yeah.
people who are fatigued, and they're still far enough upstream from the end of their life that they just want to have a little more energy and they want to have an appetite. And so
Mm-hmm.
we'll give a little steroids, perks them up. They feel so much better. But yes, if you give too much, they can be agitated. It can cause problems with sleep, severe insomnia. Give them earlier in the day. Steroids
Mm-hmm.
are also good for pain relief too. Uh, so yeah, we love steroids, but can't use a lot for a long time because it can be detrimental.
And I think this is a great time to pause and get a little deeper into morphine. Why
Mm.
and how does morphine work? People are so freaked out about morphine. We know in hospice it is the gold standard, but what makes it the gold standard? I think now would be a good time to explore that.
Well, people will read the box of morphine and they'll see on there where it says may cause respiratory distress, and that's their
Mm-hmm.
panic, right? May cause respiratory distress. That's why it works. It slows the breathing down so people can get their breath. It's also, as far as opioids go, probably on par with any other opioids that we give for pain. And by the way, other opioids can work for shortness of breath as well. But morphine liquid works very fast. Put in the mouth, works very fast, and it's cheap.
Mm-hmm.
And again, we hate to say it, comes down to the almighty buck, but when it comes to hospice, we aren't reimbursed at a very high rate. And people don't understand that. We could do a whole, I don't want to go, I'll take us down another rabbit trail if I do this. I don't want to talk about the difference between how hospice is reimbursed, but it's an inexpensive drug. It's tried and true. We've used it for decades, centuries probably, right? Like they used morphine opioids way a long time ago, but it just works very quickly and it eases the respiratory rate to help people catch their breath. And that's why we love it. And that's why it's the gold standard.
Yeah. Yeah, I was actively listening to you and I lost my thought about morphine. I'm sure it'll come back to me. I'm thinking about, it's used for so many different things. It's used for the pain. It's
Hmm.
absolutely used for shortness of breath. We're
Yes.
talking about really small doses. And I know I've heard
Yes.
you say this, Penny. What equivalent of the dose of morphine that we usually start on? I know you've equated that to like a Vicodin. That's
Percocet.
another thing I think
A
is
Percocet.
a Percocet.
Yeah.
It's
It's
a
about the
great equivalent.
same. It's about the same as a Vicodin, but it's actually less than a Percocet because oxycodone is what's in a Percocet, and that's 7.5 milligram equivalent to 5 milligrams of morphine. So in other words, if you give 5 milligrams of oxycodone, that's equivalent to I said it backwards. If you give 5 milligrams of oxycodone, that's equivalent to 7.5 milligrams of morphine. It's more potent per milligram than morphine is. And people often do not have a problem with Percocet. Give me all the
Exactly.
Percocet, but morphine, no, no, no. And we usually start people who are opioid naive on 5 milligrams of morphine.
Mm-hmm.
That's what we usually start people at. So it's
Which
it's
is literally just drops if you're doing liquid. It's
it's
not
not.
very much at all.
It's 20 milligrams per mil, so it's 0.25 mils. And that's another reason why we love it, because we can give it in the mouth
Mm-hmm.
and somebody doesn't even have to be swallowing to be able to have the effect, because it can just drip down the back of the throat slowly and seep in and absorb in and be really effective in a small dose.
And I
And
don't
we
want people to have unrealistic expectations. You're not going to just put this in your mouth and it works as fast as a nitro. It's not instant,
Right, right.
but it
It works
will.
quickly though. It does
Yeah.
work. It does work quickly. And
Mm-hmm.
people, it's so, I don't know about you, Hallie, but and maybe you haven't had this experience as a social worker. You've probably seen this, so where somebody's hesitant to take it, and we finally get them to agree to it, and it's just like a miracle for them.
Mm-hmm.
They're like, "Oh my God, that works so well! I could breathe again. I feel so much better." It doesn't take a whole long time. Like you say, it's not as fast as nitro, which is instantaneous practically. But
Mm-hmm.
morphine, 15, 20 minutes later, they start to have an ease in their breathing, and they feel so much better.
And for the symptom of shortness of breath, that's why you have a holistic team. You have your nurses and your docs that are the experts in medication, and they're going to talk you through that. To your point about being hesitant to take medications, we've had folks take literally a drop of it while the nurse is there to make sure that they feel comfortable being able to take it and know that it's not going to have this huge effect. But then we have the social worker side, the counselor side, will talk you through all of the things that will help you with your breathlessness while you're waiting those 15 to 20 minutes for it to take effect.
Right.
That could
Right.
be a fan. That could be reading a poem to yourself, or playing music, or doing a guided meditation, or breathing exercises while you're waiting for that medication to take effect.
I'm so glad you brought that up, because as a nurse, I do always educate about the medications, but non-pharmacological interventions are also utilized in hospice very well. I mean, they're very effective. And
Mm-hmm.
so, like you say, a fan in the room, cooling the room down. You can't breathe in a warm, stuffy room. The tripoding, helping people to sit up and lean
Mm-hmm.
over, can help. So, yeah, non can't talk. Non-pharmacological interventions are very, very effective for many of the things that we treat.
Mm-hmm. Well, and speaking back of, you don't have COPD, do you? Speaking of COPD, what kind of death would you expect to see before active dying? What
Yeah.
kind of at the very end are we expecting to see with folks?
So we're going to see an exacerbation of shortness of breath. They're going to have much more difficulty breathing. People with COPD are usually going to have oxygen because they want to. I always say oxygen is for comfort in hospice, and not everybody is comfortable with it. The exception is COPDers. They love their oxygen. So they're usually going to be using oxygen. They will probably be in a recliner or sitting up in their hospital bed most of the time, because you really can't breathe when you're laying flat. Also, we can see hypoxia, which is a lack of oxygen to the brain, which can cause extreme confusion,
Mm-hmm.
agitation, confusion. We do see that. I've had several patients like that who were so confused and agitated. And again, cranking up the oxygen isn't necessarily going to help them. So we often will have to treat them with haloperidol, which is an antipsychotic, or lorazepam to calm their anxiety. Lorazepam and morphine together are just a really wonderful combination of drugs to help people be more relaxed and breathe better.
Mm-hmm.
But yeah, COPD patients can be climbing the walls because they're so short of breath, and then the hypoxia can really cause them to be so confused and agitated. Also, we are likely to see more of the kind of uh, like blue modeling, hands, feet, nose, ears, lack of tissue perfusion where oxygen is not perfusing through the body. So we're going to see more of that kind of loss of color, or blue or marbled color. Oh, circummoral cyanosis, where they're kind of pale around the mouth. That's really normal as well.
Yeah, I don't think we mentioned that in the heart failure or heart disease part, but
Yeah,
yeah,
we
the
can. That would be something in those too.
cooling in the extremities, having more difficulty with circulation in your extremities, that kind of thing.
Right. And that can happen with all diseases, but especially with anything that's really greatly impacting the circulation of oxygen through the blood.
Yeah, and both of those diseases, and specifically I'm thinking about COPD, we are going to see folks as they typically would, because we're using more symptom management. They're going to probably be sleeping more.
Right.
And, that's it. Yes, we're likely to see more shortness of breath. And that's why it's great to have this extra support of hospice, because we are the experts in that kind of symptom management. And we can move quickly to change the medication or adjust the medication to make sure your symptoms are covered to the point that you want them to be, because maybe you don't. That might even involve things like a nebulizer, which are a little less,
Let's
we
talk about
haven't talked about a nebulizer.
nebulizers. Oh, yes, yes, yes. Thank you very much for
Mm-hmm.
reminding me. That's another thing. So people will often come to hospice with their Spiriva inhaler and their little albuterol inhaler, and they're married to them. They use them way, way more than they're supposed to. Again, albuterol is a steroid, and they shouldn't be using that very often. And then it's a rescue inhaler, and so they are going to. Uh, we don't like the Spiriva because it's a powder, it's a capsule that the inhaler punctures the capsule and releases a powder. Very, very expensive. Another one, expensive
Mm-hmm.
again. But also, people who have COPD lose their ability to inhale those. Like they don't have an effective inspiration anymore. So it's hard for
Right.
them to actually breathe those in. And so we have to usually switch them over to a nebulizer, which is like a steamed medication. And it'll be albuterol, epitropium, combination of those two sometimes that they can, we call it a peace pipe because it looks like a peace pipe, and they could just inhale the steam, and that's more effective. But getting people to switch over is often a challenge. They don't want to let go of the rescue inhaler, even though really it's not going to be as effective for them because they can't suck that into their lungs anymore. They don't have the ability to suck it in as far as they need to for it to work.
Suck it in and hold it. I mean,
Yeah,
that's what's great about the nebulizers is as you're changing, as you're declining, excuse me, it's a much more passive situation. So we even have like the masks. If you're physically not
right,
able to hold the peace pipe, then we can put a mask on you and you can just have that just as a passive breathing option that
right.
does open up your airway and relieve that and also get out some of that gunk because you're also getting that kind of phlegmy,
Yeah.
congested feeling.
Yeah, that'll loosen that up better than the inhalers will because
Mm-hmm.
it's steam. I'm thinking I'm the nurse, and you keep bringing up the interventions that I'm completely forgetting about.
Only because I've been around amazing nurses and I'm here to support what they're doing with the patients. I mean,
Right.
again, holistic team. I am not the one
Yes.
making these recommendations. I am supporting the education that the nurse has given. That's really
Right.
one of my roles is to support, oh, hey, I'm at this visit, but I see that you're short of breath. Well, let's talk about what the nurse has offered you and see if that might work in the situation. And then and same with if a nurse is there and they're seeing someone short of breath and they're giving medication, they can say, okay, what did your counselor talk to you about as far as the non-pharmaceutical options?
Right.
Teamwork.
Yeah. Teamwork makes dream work.
My least favorite
Anything else
phrase.
I forgot? Did I remember everything else about COPD? I think we covered
No, I
everything,
think that's
right?
pretty good.
Yeah, steroids. I did think of steroids,
Well,
inhalers,
and COPD
nebulizers.
is really, I mean, heart disease also, but COPD is the first one on our list that it kind of leads us into the lung cancer discussion, which is we're talking about diseases that some folks feel like are self-inflicted. They're
Right.
lifestyle choices that came to this. There are health options. Some of this is genetic too. And regardless of how you get to this disease, regardless of how you come to hospice, we are going to treat you the same. But I want to make sure we're clear with folks that sometimes people get the wrong impression that it is self-inflicted. Regardless if it is or not, we're treating you the
Hmm.
same.
Yeah, people can get lung cancer without ever smoking a cigarette. I want to touch on something else about COPD as far as what dying looks like. Dying looks like a roller coaster for
Mm,
people with COPD. And we often will have patients with COPD who come onto hospice in the fall, when the weather's changing, they're getting the flu, they're getting sicker, and then come late spring, summer, they improve, and now we think they're going to live longer than 6 months and they're not going to be on hospice anymore. So this is one of those diseases where we do see long length of stay and frequent flyers. They come
mm.
on, they go off, they come on, they go off. COPD is very, very hard to prognosticate. And many of our patients with COPD will end up in the hospital on a vent because even if it's not their plan to be in the hospital on a vent, they eventually, when they get this severe shortness of breath, they call 911, the paramedics come, and let's transport to the hospital, let's intubate. That's what happens often with COPDers because that not being able to breathe is such a horrific feeling for people. Suffocating to death is awful. And so I've had lots of patients who ended up back in the hospital, in the ICU, back home again on hospice, back in the hospital, ICU. Very, very much the roller coaster hospice stay.
And it's hard for caregivers to watch that too. I mean,
Yeah,
your loved one is going through this thing that's suffering, and you have been taught all your life that if there's a medical emergency, call 911.
right.
So it is your default to do that. It doesn't matter about our education. Most of the time, people do default to that. And,
Yeah,
it's okay.
yeah,
We're not judging you for that.
right. All right, let's move on to our next disease.
All right, so we're going to slide right into lung cancer since we're already talking about respiratory issues.
Lung cancer. So yeah, people can get lung cancer without ever having smoked. They could get it from secondhand smoke, or they could get it just because it's genetic and they can get it from that. Lung cancer will typically metastasize to the bone and the brain. So we can start to see pathological fractures when people have lung cancer. We can see confusion, agitation because of the brain involvement. It can be painful. Lots of times it causes back pain. I've known of patients who died from lung cancer who just thought they had a backache from, lifting too much furniture during a move, and come to find out they have lung cancer. Symptoms are going to be similar. Otherwise, as far as respiratory to COPD, they're going to have lots of shortness of breath with lung cancer. They can have the same kind of hypoxic reaction where they're not getting enough oxygen to the brain, so that's causing confusion as well. Treatment's going to be similar. They're going to be getting steroids. They're going to be getting oxygen. They're going to be getting inhalers, nebulizers, that type of thing.
And steroids, I hear, is very good for bone pain
Yes.
specifically.
Yeah, steroids is excellent for bone pain. Absolutely. If people have mets to the bone, steroids work fantastic for that pain.
And that would be an instance where we wouldn't be probably more of the burst symptoms like respiratory, but like a low dose ongoing, yeah?
Yeah. Yeah, usually dexamethasone, 4 milligrams twice a day, early in the morning and late in the afternoon, so that it
Yeah.
doesn't keep them awake. Yeah.
Lung
Yeah.
cancer does seem to be one of those tricky ones where folks often won't find out that they have it until really late because the symptoms are mild, maybe, or folks are just hesitant. They're the type that are very stoic and don't think anything is wrong. And then by the time they go in to find out, it's really too late.
So the earliest sign of lung cancer is usually going to be bloody cough, coughing up sputum that has a little blood tinged sputum in there. And then again, you can have back pain with lung cancer. It's another sign.
So interesting. All these 3 diseases we've talked about so far. How many folks have you had that have this pursed lip, shortness of breath, breathing, and you ask them if they feel shortness of breath, and they say no?
Yeah, they live. Their O2 sats are in the 70s. They live in the 70s. That's what we say. They live in the 70s. They live in the 80s. That's what they're used to when they're, when you check in O2 sats, they're low, and people might freak out. Oh my God, 75%. That's what they're at. That's what they live at. They're used to that. They do compensate with the pursed lip breathing.
Yeah,
So
that's
yeah,
exactly why I bring that up, is because numbers, people can be just so wed to these numbers, and it really is about how are they feeling.
right. Exactly. And so speaking of pursed lip breathing, that is just pursing your lips and breathing little short breaths to help you
Yeah.
breathe better. So speaking of lung cancer being caused by smoking, which it can be, I mean, it is the number one cause of lung cancer, but people can get lung cancer without smoking. Smoking also is the number one cause of bladder cancer.
Interesting. I did not know
A lot of
this.
people don't know that. Yep. It is the number one cause of bladder cancer. Our whole vascular system runs throughout our whole entire body. And when you're taking nicotine in, it's going everywhere, and it can cause bladder cancer.
Yeah. Coming back to smoking, I'm thinking about so many of our folks that continue to smoke while they're on hospice.
Yes.
And so I want to talk about 2 different things with this. Number 1, we're not going to ask you to stop smoking. It's too late anyway. It's really not going to help.
The ship has sailed. It's too late.
But I also want to talk about the fact that oxygen, talk about oxygen safety for us.
Right. Oxygen safety. So oxygen is flammable. And people will say, no, it's not flammable. It won't blow up. Like, tell that to my patient who burned down his trailer that he was living in by smoking a cigarette. And here's something
technically
interesting.
It's not flammable. It's an accelerant or something like that.
Accelerant, something I
had an argument with the patient about this. So
yeah,
I don't
know the whole chemical thing. All I know is smoke a cigarette in the presence of oxygen, go boom. It happens all the time. We have had many patients who have caught their faces on fire.
Yes.
So yeah, flammable or not, there is a capacity for fire to start when you smoke.
Yes.
And I want to say, not just smoking. So at my agency, we were having a rash of people catching themselves on fire, catching their places on fire by smoking with oxygen. So we really, really started focusing on making sure that people knew they shouldn't smoke with fire or smoke with oxygen. Well, then that's what we leaned into. Like, don't smoke, don't smoke. Then we had a patient on Halloween who wanted to make it spooky for his grandchildren, and he lit a candle and caused a fire. And we realized that we were leaning too heavily into the don't smoke with oxygen, and really it should be no flame at all. No spark, no flame. You know, we have people who actually heat with wood. I actually heat with wood, but we have people who heat with wood who would be sitting close to their wood stove with their oxygen on. And the other thing about oxygen with smoking is you can take off your nasal cannula. That's the little prongs that go in the nose to deliver the oxygen. You can take that off, but you can still have oxygen around you.
Yes, thanks for talking about this.
And so you really have to air out before you smoke. Don't just take it off. Turn the concentrator off.
Yes, turn it off for what?
10 feet away from it, at least 10 feet away, and wait for a moment before you smoke your cigarette, because that oxygen can still be there and can still cause fire. So.
Yeah.
And they talk about, not using, not only smoking, not only open flame, but electric razors can be dangerous around smoking.
Anything with a spark.
A spark, right. The interesting thing is they always say don't use any petroleum products. There has never been, from what I heard from our educators, any situation that's documented where a fire was able to be spontaneously started by the presence of a petroleum product such as Vaseline and oxygen in the same environment. But that's always when they're like, don't use petroleum-based products. Probably if you were smoking or there was an open flame or a spark and there was petroleum and oxygen, yes. But it's still one of those things where they say, don't do it. And there's never been any evidence that it can cause. In fact, our education department did their own little test trying to start a fire with oxygen and some petroleum-based products that we were using, because we had a patient who was smoking in her bed. She had oxygen, and she set the oxygen down next to her and caught fire on her nether regions. And they were using a product on her skin that was petroleum-based. And so we were thinking, did that cause the fire? And they did all kinds of testing, and they could never reproduce any kind of flame with oxygen in that product. So.
Yeah, I know they always recommend us to tell folks to use like beeswax chapstick.
Yeah.
Yeah, both of us, you and I both have had patients that have had horrific outcomes from smoking and oxygen. I can't describe it. It's awful. And I've had a patient that didn't die right away after that.
We had one that was on a vent in the hospital, in the ICU after that.
Yeah, it's traumatic. And that's just if they're the only ones that get hurt. I mean, that's not even mentioning, like you're saying, burning a house down or burning an apartment building down.
Where there's neighbors. Yes. Yeah, it can cause harm to other people in the area.
Yeah. So if you're someone that is worried about that and you just cannot give up your nicotine or, smoking, but you need oxygen, consider if you can at least take it off for a few minutes, air yourself out, turn that oxygen on, step outside. And if you can't, try to consider another way to consume nicotine.
Not vaping.
Not vaping. No sparks.
Use same thing.
A nicotine patch. Use the chew packs.
Nicotine gum. Yeah.
Nicotine gum, like anything else, because you're putting other people in harm's way, not just yourself.
But let's circle back to letting people smoke who have lung cancer or COPD. Patients, families are so worried about that. Like you say, the ship has sailed. It brought them there is probably nobody in the whole world, at least not in the US, who doesn't know that smoking can cause COPD, can cause cancer, can cause death.
Mm-hmm.
They know it,
Yeah.
but it is so highly addictive and it brings them pleasure. They
Yeah.
don't want to quit. My dad did not want to quit. He died from a smoking related disease. It brings them pleasure. And at the time of their life, when they're at the end of their life, let them have their little pleasure.
Yeah.
As long as they're doing it safely.
Yes.
As long as there's no oxygen, let them do it. It's not going to hurt anything. I will say, I've educated my patients before on this. If you're feeling short of breath and you smoke a cigarette, you're going to feel short of breath. It's not going to make you feel better respiratory wise to smoke.
Although I've had
But,
people argue that with me, that they feel better while they're smoking.
well, it's probably psychological
Yeah.
because of the anxiety reducing
Mm-hmm. And the addiction
component
part of
of
it.
smoking and the addiction part of it. Yeah, I had a patient who was 42 years old with lung cancer, and she smoked. She'd go out back and smoke. And when she could no longer hold the cigarette, the aides would hold the cigarette for her so that she could smoke. Because she'd be slumping over and dropping the cigarette in her lap, and the aides would hold it for her so she could smoke. It's the only thing that brought her pleasure anymore. You know, she couldn't do anything else. So yeah.
I will add on for folks that may end up having to use placement for care for their loved one, that almost no facility anymore. Very, very rarely can I find a facility that allows for smoking.
Yeah. They used to have like a smoking area, but they don't do that anymore. You
In
might
fact, I
find
think
an
there's
adult family
only
home.
one that's not an adult family home in anywhere in the big area that I serve that does allow smoking. So it's pretty rare. And that's a hard transition. You're already being moved into a facility, and then you're going to have to give up smoking too. And it's a lot. So that's just something to consider. I'm not saying you have to quit. I'm just saying, as a system of care, consider that is something you will have to look at if you're looking at a placement option.
Right.
Probably the last thing on the list people think about, but it's important.
And I don't know about your agency, but so nicotine patches aren't generally considered a covered medication for hospice patients, but we typically will make an exception and cover them for people who are
especially if
smoking.
it's a placement situation. Yeah. I mean, it's case by case, but we have done that. Yeah.
And I mean, it's a comfort med, so it really kind of should be covered by everybody, but I know not everybody will cover them, but sometimes they get covered.
Yeah. All right. The next disease, just as we're talking about cancer and we're finishing up this conversation, before we started, we had been talking about breast cancer.
Oh.
And the reason
and also, we're not going to take a deep dive into every cancer there is because there's too many cancers.
No.
But we're touching on kind of the ones that we see that are most significant.
And specifically what we were talking about was when people, for one reason or another, choose or don't have the option to get this treated, and how that can result in some catastrophic symptom management.
Right.
So tell us a story, Penny. Tell us about a breast cancer story.
Okay. So fungating tumors look like fungus. That's why they're called why it's called fungating breast cancer, because it looks like fungus. It's hard and raw and very, very painful, can leak fluid out of it, can grow. And I had two patients who were at the same time on my caseload who had fungating breast cancer, fungating tumors.
And before you get too much further, just for clarity for folks outside of the hospice world, most people, I think of cancer internally. This is something that is breaking through the skin and is outside of the body.
Yeah, and lots of cancers can do that, by the way. I've had a lung cancer patient who had little
squamous
tumors
cell
all over. Oh, yeah. But my lung cancer patient had little tumors protruding all over her little body. They were everywhere. But yes, people think cancer is internal, but it can be external. And that's what this fungating breast cancer is. It's external and it can grow very rapidly. And I had two patients on my caseload at the same time. One had undergone chemotherapy, drugs, and nothing worked. So she came to hospice. Her tumor was all the way in both breasts and all the way around into her back.
Oh, gosh.
Very, very, very painful. And she died pretty quickly after she came onto hospice. She didn't live for a very long time. My other patient was really into holistic medication and had been going to a naturopath for years and keeping her cancer at bay.
Mm-hmm.
Her tumor was quite a bit smaller, and she was treating it with food grade bleach. She would
Wow.
soak gauze in food grade bleach and put that on her tumor
Oof.
and kept that at bay. And it never got, so it had the one that was getting bigger, bigger, bigger all the time, and this one who's was growing very slowly. And I actually got an order from the doctor for my other patient who had the big one to use the food grade, it was food grade peroxide, to use that on hers. But unfortunately, she died before the daughter could ever even go and get any of that. But my other patient lived for quite a long time, and she was very resistant to taking any medications. She did not want to take any opioids at all. She was just drinking coconut water before coconut water was in fashion. She was doing just all kinds of holistic naturopathic things. Towards the end, the pain did exceed the ability for anything natural to work for her, and I was able to convince her to use a fentanyl patch,
Mm.
and that worked for her, and she was comfortable at the end when she died. But I just, the comparison between the two women who treated their cancers completely different, and how one went, versus the other one, was such a stark comparison for me. It was interesting.
Mm-hmm. Yeah, I've definitely had folks that came to us after holistic care and or religious objection to modern medicine,
Mhm.
and both with fungating tumors, unfortunately. And yeah, I don't think we're here to say what you choose to do and how you choose to treat it is right or wrong. There's no right or wrong. Sometimes folks that do holistic medicine don't stave off their cancer and they die just as
Right,
fast.
right,
Sometimes folks will live for 10 years treating their cancer and going in and out of remission. So it really has to be a decision you make about your body and with your doctors, or, with some kind of informed decision making. You just never know.
right, right.
I
You
wish
never
that
know.
that one way would work for everybody, you know?
Yeah, me too.
But I think the reason we brought that up is because we want to say it doesn't matter. We're going to still treat your symptoms the way that you want them to be treated. Like, to Penny's
Exactly.
point, is we're going to allow you to continue to use your holistic medicines
Yep.
and offer modern medicine for comfort if and when you're ready.
Right. And if you never are, that's okay.
Mm-hmm.
Yeah, exactly. We meet people where they're at. They
Yeah.
get to, they're steering the ship. They get to decide
Mm-hmm.
what they want to do.
All right. Well, let's get into cirrhosis, quote of the liver.
Cirrhosis of the liver.
This one,
Yeah.
I think, is one of the bigger, it's not controversial for us, but I think for the wider public can be controversial because people think that cirrhosis is only from drinking yourself into that state, which is not accurate.
No,
So
people
tell
can
us
get
about
cirrhosis.
cirrhosis.
Don't drink. Yeah. Cirrhosis of the liver failure. Basically, your liver is failing. So your liver is it's the toxin cleaner of your body. It's your filter in your body that filters out your blood and filters out everything bad out of your blood. And when people get cirrhosis, which they can get from drinking too much alcohol, and they can also get it never having drank alcohol, which is more uncommon, but it can happen. So don't
Mm-hmm.
assume that somebody with cirrhosis of the liver is necessarily somebody who is a drunk, right? Somebody living on the street, pounded down Mad Dog 2020 24/7. It's not necessarily caused by alcohol. So people with cirrhosis of the liver are going to it's another roller coaster type of progression towards the end of life. And that's because the liver, to some degree, has an ability to regenerate itself. So sometimes they'll get better, and then they're worse again, better, and then they're worse again. So we see with cirrhosis, fluid building up in the abdomen. That can happen. And by the way, we can also see fluid building up with lung cancer too, around the chest, or heart disease. And we can drain that off. So in cirrhosis, it's called ascites, and people will literally look like they're 10 months pregnant. They have huge, huge belly. It's all fluid that's in there, and that can be drained off. They can go into interventional radiology and have that drained off, or we can put a tube in called a Plerex drain or an Aspira drain that they have in there permanently, and then we can drain them at home to help people stay at home. They get levels of ammonia because the filter's not working anymore. We're going to see more levels of ammonia rise in the bloodstream, and that goes to the brain, and people can be extremely confused and agitated. Very, 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 very confused and agitated. They are not themselves at all when they're like this. We can also see jaundice, which is kind of a yellowing of the eyes. Usually the eyes first are where you're going to notice it, where the whites of the eyes become very yellow, and then the skin yellows. That is not really necessarily painful, but it can cause a lot of itching. So cirrhosis of the liver can cause pain. It's not as painful as some other diseases, really more the confusion, agitation, and the ascites. The ascites can cause pain. All that pressure in the gut can cause pain.
And shortness of breath.
And shortness of breath, yes. Ascites can cause shortness of breath because, again, you got all this fluid in the belly pushing on everything inside, and that's going to make you have a harder time breathing. One of the drugs that we use to treat cirrhosis is lactulose, which is a disgustingly sweet, thick, syrupy medication. And I know how disgusting it is because my daughter was treated with lactulose when she was a toddler for constipation. And I tried it, and it was disgusting. She loved it, but it was horrible. But the way that it works is it causes people to basically shit constantly, because that's how they eliminate these toxins from their blood, is by shitting. And so they don't want to take it because it causes so much diarrhea. And they have to drink so much of it. And it is disgusting. If you're not 4 years old, it's disgusting. So they don't like taking it. And then sometimes people get beyond the point of where it's going to work anyway. So we can do Aspira drains, like I said, or Plerex drains for the fluid. We can do the lactulose if they'll take it. They won't. And then we can do haloperidol antipsychotics for the agitation. We can do opioids for the pain if they're having pain, for the shortness of breath, as you pointed out. Yeah.
And
it's
as
bad.
people are listening, they may think, well, why can't you just use that drain like a faucet and keep draining it out? I know for our folks that have gone through this, personally and professionally, I've had folks that in my life that have had to deal with this. There comes a point where, number one, it's painful if you don't have the drain already and you have to get jabbed. But also, it's not one big pot of fluid. Like sometimes there's tiny little fluid pockets everywhere, and there's no possible way to drain all of that because you'd be stuck 50 times.
Yeah, we can drain the majority of it, but not all of it. And also it gets worse and worse. You would never be able to keep up with it. It just continues to get worse. So people might come on to hospice. They're still going to interventional radiology once a week. And then after a while, we're draining that drain in their home every day because there's so much fluid building up. And you can't drain off too much at one time too, because that can cause problems as well. People can get very hypotensive, meaning their blood pressure will really drop. It's dangerous to drain off, and it can be a source of infection.
Yeah. And you're also draining off essential elements like sodium and potassium and other chemical issues that happen. So It's not just as easy as, turn on the faucet and let it drain.
Right. Right. It's not that easy. And it can be painful to drain it too. It can give them relief, but it can also be uncomfortable
Mm-hmm.
to drain it off. So
Yeah.
cirrhosis is one of the I I don't like cirrhosis. I don't like it. I don't like any diseases that are terminal, but cirrhosis is especially bad. And I've had patients who were lovely, and then all of a sudden they're not. And then they're back to themselves again. And then they're awful again. And it's just such a roller coaster. It's really, really hard for the family to see somebody go through that. And, I did a video. There's a woman on TikTok who has had liver failure because of drinking too much alcohol. And she was a young woman. And most places will not do a liver transplant unless you've had at least 6 months to sometimes a year of sobriety before they're willing to do a liver transplant.
Mm-hmm.
She was in a teaching hospital where they actually took it on a case by case basis. And she was a single mom, young woman. So she got a liver transplant. And I stitched her video to talk about the fact that, liver disease, cirrhosis, is caused by self-harm, by drinking too much alcohol, but alcoholism is also a disease. So I like the fact that they can do liver transplants sometimes for people who have ruined their liver by drinking too much alcohol. And there were people in the comment section who absolutely vehemently disputed that and said, if you drink yourself to death, then you should not get a new liver when other people are waiting for a liver. Now, I never said that they should be prioritized over somebody who's young, who has uh, fulminating cirrhosis that never started from alcoholism. It started by something else or some other reason for their liver failure. I've never said they should be prioritized. I'm just saying they should be given the chance if that's available for them. And
We
people
could
were
do a
just,
whole other episode
uh,
about donations. I have a lot of
oh,
soapboxes
oh,
about
yeah.
that.
You just, you drank yourself to death. You don't deserve to have a new liver. But there
Mm-hmm.
again, we're looking at other diseases where people have a person can have idiopathic pulmonary fibrosis, is what my dad had, and qualify for a lung transplant. But they caused it by smoking. So what is
Yeah.
it's almost like there's more stigma around drinking too much and causing your liver to fail than there is around other things that cause people to have health issues.
Mm-hmm.
It's very stigmatized.
Well, we didn't go through prohibition for nothing, I guess. uh, yeah, you cut out there just for a second, so I don't know if you heard me. I have so many soapboxes about organ donation, so I don't want to go off on that. Talk about a rabbit trail. I could go in a
Yeah.
whole other state with that. But coming back to the drinking and having it be self-inflicted, I mean, as a social worker, I'm thinking about why people are drinking and the likelihood that something not great has happened to cause them to use that as a self-medication.
Mm-hmm.
Why we use that as a moral righteousness that they can't get healed or get care or get a donation, organ transplant. It's infuriating. So yeah, I just want to
Right.
reassure folks when you're coming to hospice, number one, we're not going to tell you to stop drinking because frankly, it's going to cause more harm and could kill you
Yeah, that's
if
true.
you abruptly quit.
It is like maybe the only drug that will kill you if you stop it abruptly.
Yeah. I mean, we've gone so far as to have family ration out so that they can reduce alcohol use as people are declining just to avoid the detox effects of alcohol.
Well, and people are going to want to know too, what if they don't do that? Then what do we do? Well, then we treat them with other medications as they're going through their withdrawal for
Yeah.
symptom management. We treat them with lorazepam, we treat them with morphine. We give them what we need to make them comfortable as they're going through that. The outcome is death either way, but
Yeah.
that's what
Yeah.
we're going to do is make them comfortable at the end of their life.
Mm-hmm.
So,
Oh, goodness. Cirrhosis. All right.
yeah.
The last thing we're going to talk about today, since we're already, I can't believe it, an hour in, because you and I could
Yes,
talk all day long, I think,
I know.
is about diabetes. And this
Yeah,
is another one where it absolutely can be genetic. There's different types of diabetes. It can be lifestyle affected,
yeah.
but there are a lot of differences when we're getting into end of life about diabetes. So tell us a bit about that. And I don't know if you have had anyone, I don't remember having anyone come on specifically only for diabetes, but it's a pretty big factor when we're talking about terminal illness.
Yeah, it's not really considered a terminal illness. So we don't usually have people with diabetes as their terminal diagnosis or their hospice diagnosis, but it can be a comorbidity. And you have all kinds of things that fail when you have diabetes. So you're going to have respiratory problems sometimes with diabetes. You're going to have um, vascular problems. So we see people who lose their toes, lose their legs because they've had vascular issues. So they have gangrenous wounds on their feet and their legs and their hands sometimes too. Uh,
And
yeah, so usually,
oftentimes you're not going into the hospital for that because you're already, like I said, at the end of your life from something else. And so
right,
you're not treating it with a typical what would be like an amputation.
right. And so sometimes we have body parts that fall off of our patients while we are there with them in the home.
Yeah.
That's fun. We don't try to tightly manage blood sugars for people who have diabetes. We usually are steering away from doing long acting insulin. We're usually going to switch over to checking if they're symptomatic, not checking all the time, but checking if they're symptomatic and then treating them with a short acting sliding scale insulin because people are going to eat less as they're getting close to the end of their life. So it's very, very difficult to try to balance out insulin with diet when somebody is at the end stages of their diseases and they're on hospice. I'm trying to think of comorbidities. I just say it, don't spray it. I'm just spitting on my computer. Uh, I've had patients who usually, I'm trying to think of with my patients that had diabetes what their primary was. And I want to say it seems like renal disease,
Mm,
maybe heart disease, that it goes kind of hand in hand with those diseases.
that's a good question. I'm going to have to start paying more attention to see what the
Yeah.
commonalities are. I love that you talk about just not poking someone as much to get that blood sugar,
Mhm.
because the same with the oxygen saturation levels.
Yeah.
We are not focused, we hospice, not focused on the numbers, but more of the how are you feeling and how are we going to manage that. But when you've had a lifelong, you have to be on top of these numbers or else, that's a really
Right.
hard transition, especially for caregivers.
Right. We always want to ask ourselves, what are we going to do with the information?
Yes.
And
Yeah.
if we're not going to do anything with the information, then why put somebody through that? I don't know about you, Hallie, but to me, a finger poke is way worse than like a blood draw in my arm.
Yes.
I don't like finger pokes. I hate finger pokes.
Mm-hmm.
It's very uncomfortable. So, and we actually don't you we will pay for insulin, but hospice nurses typically are not going to be checking the blood sugar. It's going to be the patient or the family
Mm-hmm.
because I don't know about other states, but I actually think it's a federal requirement. It's called a CLIA waiver, and it's something that allows us to do point of care testing in people's homes. So that would include the PTINR machine that I talked about earlier, where we can poke people's fingers and put the strip in, and we can see what their reading is for their warfarin therapy. And so we can do lab draws. But if we're using equipment to do a test on somebody, then we have to be comped in it. We have to be comped in that. There has to be a competency done.
Mm.
And because there are so many different glucose monitors that out there, there are just dozens of different brands of glucose monitors. We can't be comped in every single one of them.
Mm.
because patients own their own monitor. So we can't be comped in them. So we don't typically do the blood glucose tests. It's going to be a family member or the patient who's going to do the poking and checking the
That is an
blood.
interesting point and totally makes sense. I would have thought we didn't do it because we're not there all the time. It's just a common misconception
Well,
that
like
we are
if we're
there.
there though, yeah, we don't do it if because we're not there all the time. But if we're there
Right.
and they're symptomatic, then we might be looking at they need to check the blood sugar, and
Mm-hmm.
but we're going to ask a family member to do that. We're not going to be the ones to usually do that. We might help them by poking the finger and showing them how to put it on the strip and where to put the strip and all of that. But
Yeah.
yeah, it's really hard to manage blood sugars in somebody who is uh, at end of life.
So yeah, I think to the point, diabetes is generally not going to be your terminal diagnosis. So it's not necessarily going to be what we're focused on most, but it certainly
Right.
can contribute to symptoms. And most of that's going to be around the natural lessening of your appetite, lessening of eating, and managing that. Yeah.
Right. Yep. Exactly.
All right. Well, that is all of the diseases I had listed for us to talk about today. Do you have some kind of final wrap up thoughts on diseases that may otherwise be considered self harm or contributing to?
Oh, I mean, we could think about a lot of diseases in terms of self-harm. If we look at breast cancer can be caused by estrogen, and people use estrogen or birth control, that can cause breast cancer, and colon cancer can be caused by poor diet. And there are lots of diseases that could potentially be caused by our lifestyle choices. But I think it's really important not to focus on that at the end of a person's life. We
Mm-hmm.
don't want to treat somebody like they are less than because they may have done something that caused their own death. We don't know the circumstances behind that, right? Like you said, Hallie, we don't know.
Mm-hmm.
We don't know if somebody is eating a poor diet because they can't afford a good diet. We don't know if they're smoking cigarettes because they were abused as a child or lived in a household where they didn't have any parental guidance or good role models and they started smoking at 9 years old. Or
Or they were given cigarettes in their rations when they were in the military.
yes, yeah, were you given cigarettes in your rations,
No,
Hallie?
thank God that was done by the time I went through. But I mean,
Okay,
for the older generation, yeah, that was the thing. That was a not only a coping mechanism, but they were handed out for free.
that's true. That's true. Yeah, so I think it's important not to ever lay blame on somebody. Like if you want to be mad at somebody for or something for your person having lung cancer, be pissed off at big tobacco companies, but don't be mad at your person. And I
Mm-hmm.
think it's normal too, though. I want to say I think it's normal for people who are grieving to have anger and to need to know where to channel that anger. And sometimes it's at their person. I've heard that. I'm sure you have too. You're a social worker. You've probably heard it hundreds of times that somebody is so angry because Mima kept smoking, and if she
Mm,
would have quit smoking, she would have lived longer. And now I'm losing her because she didn't quit smoking.
yeah.
But the fact is, there are people who smoke who live to be in their hundreds, and then there are people who don't smoke who die young of cancer. So I think it's just important to meet people where they're at when they're at the end of their life, and to not try to lay blame on anyone for choices that they made that could have
Death
potentially
comes to us
caused their
all.
death.
And even
Death comes to us all.
healthy
Yeah.
people can drop dead of a heart attack. You don't
Yes.
know. People that didn't
Yes.
smoke may have been raised in a smoking household and got something from
Yep.
secondhand smoke. I mean,
Right.
blame is not going to be helpful in your end of life time with that person,
Right.
whether it's you or your loved one. Do you
Yep.
want to spend your time being resentful and have complicated grief? Or do you just want to enjoy the time you have because we're all going to get there? And that's, I guess, up to you to decide. But for us
Feeling
in
resentful
hospice, yeah,
and then feeling regretful.
yes, yeah.
Resent leads to regret. So yeah, death comes to us all. And on that note,
Well, if we come to hospice, just know that we're not going to be the ones judging you. We're going to help educate and treat your symptoms and try to give you the best quality of life you have Because ultimately, someday we'll all be dead. But what do we have to do to remember?
Remember to live.
That's right.